Now it is my great pleasure to introduce the next speaker. The next speaker is well known to all of us. He has been here several times before. Professor Ioannis Messins. He is from Athens. Professor Ioannis, he is the Professor Emeritus of Obstetrics and Gynecology at the University of Thessaloniki in Greece. He's going to address us on a very important subject, which I'm sure of great interest to everyone here. It is milder better than stronger stimulation in women with poor ovarian reserve? Sir, we look forward to your presentation. Thank you.
Thank you, Professor Gamal Serur, for the kind invitation. Dear colleagues, it is my pleasure to be here in Cairo again. Regarding this particular talk, I have nothing to disclose. And this is the outline of my talk. Some definitions first, and then briefly some principles of ovarian stimulation, and then about mild versus conventional protocols, and some conclusions. Now, regarding definitions, it is important to emphasize that when we say poor ovarian reserve is something slightly different from poor ovarian response. In fact, women with poor ovarian reserve are predicted poor ovarian responders. And there is a variation among the different studies regarding the criteria that are used to define poor ovarian response. And the most popular definition, as you know, is the one using the Bologna criteria. There are 3 criteria, and 2 of them should exist. And there are specific cutoff levels for this age, oocytes, and reserve tests. There is also another classification. We heard about it this morning. The Poseidon criteria are used in this. There are 4 groups, of course. There are the same criteria, in fact, age, AFC, AMH, and oocytes, but the cutoff levels are different. Now, regarding mild ovarian stimulation, the definition that has been given by Bart Fauser is that we use a low-dose FSH, which limits the number of oocytes to less than 8. While conventional ovarian stimulation protocol, there is no consensus regarding the starting dose of FSH, although a dose of 150 units is acceptable. But in some studies, of course, there are higher dosages, even up to 450 units. It is considered an optimal number of oocytes to be between 8 and 15. Briefly, some principles of ovarian stimulation. We know that the intercycle rise of FSH or FSH window that takes place during the luteal follicular transition is responsible for the selection of the dominant follicle. And of course, during the normal menstrual cycle, only one follicle will grow further to become preovulatory. Interventions in order to increase the number of follicles selected and have multiple follicular development and growth include the raising of FSH levels, well above the threshold, of course, and widening the FSH window. Now, to raise the FSH levels, we use mainly exogenous gonadotropins, exogenous FSH, and we have demonstrated some years ago that there is a dose-dependent increase in the levels of FSH, and also there is a dose-dependent response of the ovaries to the FSH with the higher dose of 450 units increasing estradiol concentration significantly within 24 hours. If we focus on that dose, in another study, you can see that FSH increases certainly for about 2 days and estradiol for about 3 days, suggesting probably multiple selection, but eventually the levels become similar to those in spontaneous cycles, which means that if we in fact increase the FSH well above the threshold, but only for a certain period of time that is restricted to the period of the intercycle rise, yes, in that case, we have multiple follicle selection, but there is only single follicle growth. So we need to give FSH for a further period of time, which is, of course, to widen the FSH window. So this is the protocol that is used nowadays, which can be mild or can be conventional, depending on the dose of FSH that is given. And of course, there is multiple follicle selection and multiple follicle growth. There is, however, the possibility to expand the window only to widen the FSH window, and this is the mild ovarian stimulation approach. And in fact, in that case, the low-dose FSH is used starting on the 5th or the 7th day instead of the 3rd day of the cycle, which in that way rescues those follicles that would become atretic because of the termination of the intercycle rise of FSH. So in this case, there will be multiple follicle selection and multiple follicle growth, but the numbers will be lower than with the conventional protocol. Now, what about the use of the mild versus conventional ovarian protocols, stimulation protocols in clinical practice? Certainly, we are interested about the poor responders, but if we look at this study, which is a randomized controlled trial, this is in normal responders by the group of Bart Fauser, which compared two groups, the mild stimulation, 150 units starting on day 5, not on day 3, in the GnRH antagonist protocol with single embryo transfer, and compared with the standard protocol, 150 units per day in a long agonist protocol and double embryo transfer, you can see that at 12 months, there was, in fact, a similar cumulative live birth rate between the two groups, which is important that the mild ovarian stimulation, at least in normal responders, is not inferior to the conventional stimulation. Our experience in the use of the mild ovarian stimulation is derived from our unit in Larissa in Greece, which is the university hospital, the university department. And you can see that for the period of 2002 up to 2011, it was in fact the time, 2011, when we were visited by ESRE and EPCOC for accreditation of our unit at that time. And you can see that the number of oocytes that we obtained on average was 4.61. And if we calculate in this slide the cumulative live birth rate during the last 3 years, in fact, out of this period, which goes between 2009, 2011, 373 women, you can see that the cumulative live birth rate is quite good, in fact, 50% after 6 months. And we have to consider that there was a mixed population, including women with low ovarian response, also normal responders and hyper responders. And also this meta-analysis, this is from the group of Geeta Nargood from London, where it was a comparison between mild ovarian stimulation and conventional ovarian stimulation in normal responders. The live birth rate did not differ significantly between the two groups, confirming what we said before, that mild ovarian stimulation in normal responders, and in fact, this treatment started from normal responders or hyper responders in order to avoid or to prevent the ovarian hyperstimulation syndrome. Now, what happens to the poor ovarian responders? This is a systematic review in 2012 from Netherlands that included mainly studies that were published before 2010. According to the estimate, it was found that, in fact, the clinical pregnancy rate was much lower than in normal responders, which probably could give us the idea to increase the dose of FSH. And in fact, this happened at that time, giving higher dosages. But if we look at this data from Monash University in Australia, there was a negative correlation between the dose of FSH and the clinical pregnancy rate. And dosages up to 600 units were used at that time, which are not used nowadays. And also some prospective randomized trials were published throughout the years, the last 20 years at least. Here you can see one randomized trial that is from Netherlands. Again, you can see two groups, one dose of 150 units compared with 300 units, and there was no difference in the clinical outcome and the different parameters. The thing is that this study included a small number of patients in each arm. And also there was only one marker that was used, or one criterion that was used to predict poor responders. It was the AFC less than 5. Another randomized trial, controlled trial, that is from Italy, from Milan, that compared clomiphene citrate with high-dose FSH, clomiphene given at the dose of 150 milligrams per day for 5 days, compared to high dose of FSH that was 450 units per day in short protocol, and there was no significant difference in the various parameters regarding the clinical outcome, live birth rate, and pregnancy rate. But again, here there was only one criterion that was used to predict the poor ovarian response. It was FSH greater than 12. And again, this randomized trial, again by Youssef from Netherlands and Egypt, regarding the comparison of a mild ovarian stimulation with a conventional ovarian stimulation, the mild including 150 units recombinant FSH starting on day 5 in a GnRH antagonist protocol, with the conventional including 450 units HMG in a long agonist protocol, and there was no significant difference in the various parameters again regarding the clinical outcome, ongoing pregnancy rate or clinical pregnancy rate, and there was a difference in the number of metaphase 2 oocytes that was higher in the conventional group. However, as I said, the two treatments were comparable. And here again, there were different criteria that were used, as you can see in different patients, either age or FSH or AFC or previous poor ovarian response, not a specific definition according to Bologna criteria or other definitions. And this meta-analysis, again by Youssef and colleagues, compared the low-dose gonadotrophins with high-dose gonadotrophins, and no significant difference between the two treatments in terms of ongoing pregnancy, clinical pregnancy, and live birth rate. And in this similar and the same study, in fact, whether gonadotrophins were combined with oral compounds, for example, letrozole or clomiphene, still there was no significant difference in the live birth rate. And this Cochrane database systematic review from Basel, from Switzerland, showed that compared, that was from Netherlands and New Zealand, that compared 450 units with 150 units, or 450 units with 300 units, or 600 units with 300 units. Again, there was no significant difference. And the same group, which is in fact the group of Brockmans from Belgium, from Netherlands, in a very recent Cochrane database systematic review, found similar data in terms of comparison between 150 units with 300 or 450 units. And also they concluded that increased FSH dosing may or may not have an impact on the clinical outcome, which is live birth rate, OHSS, or clinical pregnancy. But the evidence, the quality of evidence was quite low. And this study that is from Switzerland by Moffat and colleagues showed that comparison of different groups of clomiphene with 450 units FSH or 150 units, and then compared with placebo combined with the same doses of gonadotrophins showed no significant difference. And the primary endpoint here was the number of oocytes, in fact, but the difference, although it tended to be higher in the clomiphene plus 150 units, did not show any significant difference, apart from the number of blastocysts that was formed, and the rest was similar. And this study in poor responders, again, this is a meta-analysis by the group of Biget and Argud from London, comparing low versus higher doses of gonadotrophins or clomiphene versus high dose of letrozole plus low dose versus higher dose. Again, live birth rate did not differ significantly between the different groups. And also the cumulative live birth rate was similar, although with the conventional, which means higher dosages, the number of oocytes was higher, and also the number of embryos created. And this recent cohort retrospective study from China that has compared two groups, one is clomiphene and the other is generates agonist long protocol, both combined with the same gonadotrophins, the same dose, 225 up to 300 units, and showed using the Kaplan-Meier curves in about 48 months, which is about 2 years, the cumulative live birth rate was similar, which means no difference between a milder approach and a more stronger, which is more conventional protocol. And this goes regardless of the age, regardless of the first or second cycle. But here, again, it was only one criterion, and this was the age above 35 years. Recently, a consensus, Delphi consensus, which in fact was a two-round Delphi consensus in Spain, in which 40 fertility specialists took part in order to decide about the optimal dose of FSH in poor responders. They concluded that in this group of patients with low ovarian reserve, of course, the dose should be 300 units. This is a decision based on opinion, based, of course, on the literature, but it is, again, slightly arbitrary, although it is a consensus. And if we look at the data that were analyzed in the guideline of ESTRE, it was concluded that, or recommended at least, that a dose of 150 units, it is not clear whether if we increase the dose above that level, would provide a benefit for poor responders. And in any case, they consider that a dose higher than 300 units is not recommended. And this optimist study from Netherlands, you can see here the group of women with predicted of poor ovarian responders with an AFC between 0 and 10. There is a comparison between the standard dose of 150 units with a higher dose of 295 or 450 units, and you can see that the cumulative live birth rate, the proportion of women with a live birth rate, was similar after about 1.5 years. So overall, it seems that the use of milder stimulation, in fact, in poor ovarian responders, or at least women with poor ovarian reserve, it doesn't seem to show a lower outcome, clinical outcome, and seems to be not inferior. There are, of course, some other options for the treatment of women with poor ovarian response or reserve. Just to mention them only, I'm not going to discuss them. The short agonist stop protocol, the stop generates agonist, generates antagonist protocol, also the use of corifoliotropin alpha, progestin primed ovarian stimulation and freeze-all, of course, the duo-stim, the modified natural cycle, and the use of some adjuvants. So based on this discussion, ladies and gentlemen, dear President, just to conclude that there are several definitions of poor ovarian response, with the most popular one being using the Bologna criteria. Women with poor ovarian reserve are predicted poor ovarian responders, not definitely. Multiple follicular development can be induced by increasing FSH level and or widening the FSH window, and this can be either mild or conventional ovarian stimulation. In poor ovarian responders, mild ovarian stimulation seems to provide a clinical outcome not different from the conventional protocols. That across different studies, there is a diversity of criteria for the diagnosis of poor ovarian reserves, even within the same study, and this is particularly for the prospective randomized trials. And caution is required when interpreting the RCTs in predicted poor responders. And gonadotrophin dose of greater than 150 units is not recommended in predicted poor responders, although there are several practitioners that who accept a dose of up to 300 units. And it seems from this discussion, dear colleagues, that mild ovarian stimulation appears preferable to more intense stimulation. And before I finish, just to remind you that in EBCOG, the European Board and College of Obstetrics and Gynecology, we organize exams, fellowship exams for obstetricians and gynecologists, part 1 and part 2. And the next part 1 will be in March 2025. More information is found in the EBCOG website. That we also organize in collaboration with ESRE exams for reproductive medicine for doctors specialists in the field. And also recently we started the collaboration with the European Society of Contraception and Reproductive Health, and we had recently the first exam. And finally, this is the next Congress of EBCOG in Frankfurt in June, and you are all welcome to participate. Thank you very much for your attention.